The first idea that we need to have is the use of uterotonic drug to prevent the postpartum hemorrhage after cesarean. There is a lot of papers that mention different type of drugs, different type of side effects, different type of combination. But this is very important that you know that it's very, very variable, the different protocol. But it's very important that you understand that the first cause of hemorrhage is a failure and a lack of myometric contraction. And if you know that all the cases in which the hemorrhage proceeds ends in coagulopathy. This is a video that I try to show what is the mechanism of hemostatic after detachment of the placenta in relation with the fibrinogen. At the first, the entrance of the calcium to the myometrium produced the uterine contraction and stopped the bleeding from the vessel from the placenta. Then, a layer of the fibrinogen is over the placenta bed, but if the uterus relaxed, this part of the fibrinogen moved and reduced. This is a circle in which you have the decrease of fibrinogen level and the process starts again, and again. For this reason, it's very important that you understand that it's a time to use uterotonic drugs and then to achieve hemostasis for other methods. This is obviously one or three slides of a lot of work about the use of different combination of uterotonic drugs in relation, for example, with the use of or compare the syntocinon with other drugs, in relation with a side effect, with relation with the dose, is it better or not. You have, for example, this case in which I try to determine which is the optimum drug, the optimum dose of carbetocin. In my country, there's a lot of carbetocin, especially because one of the brands of the syntocinon is fake. And the use of this type is controversial. For this reason, in a special patient, special high-risk patient, you use a lot this type of drug. And obviously, you have another possibilities in this case to the use of isoprostol by rectal way, and this is the same. Some groups say that it's better than syntocinon, other groups that this talk about is equal, and other groups say that it depends on the side effect that do you want. This is a comparative from Sampro between carbetocin to syntocinon and the necessity to use more or additional use of syntocinon after delivery, but in relation the same. But the other part is in relation with the use of tranexamic acid. Do you know that in this moment there is a big experience in trauma, and now there is another group that try to know about what is the relation of the use of tranexamic acid in a very big sample of cases. This is a different guidelines in which you use, for example, a bolus of 5 units of syntocinon and 10 infusion in the time, but the combination are very variable. When I try to know is there is some group that is more effective than others. Do you have, for example, paper that is in favor of this scheme and papers is against? And this is try to use a simple or the less drug, the less dose that is effective, because it's in relation with the side effect of these drugs. The thing is, how can I do to prevent the bleeding after cesarean? Obviously, the first measure is the use of these uterotonic drugs, or, for example, tranexamic acid. But the thing is, how can you do when the bleeding continues? This is very important. For this reason, it's very important that you understand what is the relation with the bleeding, with the contraction of the uterus, and in relation with the start and the coagulopathy. In some hospitals, for example, it's very easy to ask for the level of fibrinogen, but in others not. And this is a simple guide to know what is the level of the bilirubin? You need to take a sample, put what is the name? A tube of glass, yes, and put behind here and stay for 10 minutes. If you move the tube and the cloth is stable, you have about over 30,000 levels of bilirubin. If you move and the cloth is broken, it's about 150. But if it's not cloth formation, it's below 250. This is a simple rule that you have an idea what's happening with this patient. Why? Because you know now that the minimum level to provide hemostasis in the placental bed is 100, 150. If you have not this level of bilirubin, the patient continues bleeding, and this is very important. You have different methods. For example, we use, different methods in relation with the area. When you analyze the three sector of the uterus, the main important is the uterine body, in which you have the main causes of uterine anatomy. In the second level, you have a normal invasive placenta, placenta previa, that is very important. This is very important to know the difference. Why? Because when you use, for example, method, for example, battery balloon, you put in the uterine body, that is not effective in the lower part. For this reason, some people use sandwich method, because you increase the pressure of the balloon in the lower part of the uterus. Why? To achieve hemostasis in that area. That area is irrigated, for example, for a special vessel in the lower part of the uterus. This is a different method that you can use, for example, to achieve hemostasis in the upper part of the uterus. Obviously, the Lynch or different Hyman procedure. The Hyman is a variation also of the variation of the Lynch procedure, the battery balloon. And there is a difference if you have, for example, bleeding in S1 sector for a normal invasive placenta. Why? Because in this area you have an edge of the vessel. It's completely different than in the cases of uterine anatomy. For this reason you use compressive suture like square suture or Pereira procedure. In the case of S2, in case of placenta previa, you use short procedure, sandwich procedure. But it's different. Why? Because it's not effective at all when you use a Lynch procedure. This is one I showed you yesterday. This is very simple. In the case that you use, for example, different type of uterotomy probe without any success, you can do this procedure with two clamps, this Satinsky clamp that you occluded, uterine artery and vaginal anastomotic system, and the upper part with the bulldog clamp. This is very simple to perform because it's very quickly, and you produce the uterine vascular exclusion. You occluded all the pedicle of the uterus. It's like hysterectomy without any procedure. This is a very old technique, but it's the use in the case of uterine anatomy. You enter for the parametrium area and you put a ruler. This is very, very simple. This is a number 2 ruler. And pay attention to the way in which you produce the occlusion. Because some people make a knot, but this is the difference. You tight, very tight, until you put the clamp. This is very important because it's not effective at all. If you put, for example, a stitch, it's not effective. This is a case, for example, that you can use. It's very simple in cases, for example, when you need to perform a myomectomy, or in cases of uterine anatomy. What is the idea? The idea is to have time to replace, in this case, for example, bilirubin level or blood or something like that. Or even if you need to use, for example, Vacri balloon, or you need to ask for embolization. Why? Because all the procedures that are hemostatic in the uterus are strongly dependent on the hemostatic state of the patient. If you have, for example, embolization, or you use, for example, Belling's procedure with a very low level of fibrinogen, it's not effective at all. This is a case of use of Eastman bandage in the case of Jehovah's Witness. It's very useful. In this case was the first pregnancy, and the obstetrician knows about this belief of the patient during the surgical room. Yes? And in this moment, obviously, first baby, the possibility of hysterectomy, put the bandage, and then the problem was the decrease after placental detachment of the level of fibrinogen. In this patient was undetectable. Obviously, the patient refused for infusion of cryoprecipitate. But luckily for us, we have a concentrate of fibrinogen. There's no problem. We replace 4 vials of fibrinogen and then recover the coagulation clot. This is the same video that I showed you yesterday. The application or the performed to use is very simple. It's approximately 5 centimeters, 1 meter long. It's very, very tight. When you apply, for example, as a sample, the pressure is very high. And the thing is, you can place this type of hemostatic procedure for 6 hours. 6 hours is a maximum time in which you provoke the vascularization of the uterus without any problem for the myometrial tissue. In general, when you use this type of bandage, it's about 40 minutes or 50 minutes to replace the volume, or to replace blood, or to replace the fibrinogen. The only thing that you need to is wait to replace the volume. But it's very effective. It's very simple to use. The thing is, what is the method that we can use in the lower part? Because the thing is that in S2 area, this is not okay. This is not able to use, for example, Vacri balloon. This is not good when you use Belling's procedure. And the thing is, pay attention to this area. In this area, you need to move the bladder down. If not, it's not possible to access to this area. But it's very simple to perform this type of compression suture. It's very, very simple. You can use in the anterior part and the posterior part of the uterus. It's very simple that you use a big cream or cardboard, and you compress this area. But why you compress this area? Because you can stop the bleeding or the blood flow, the vessel from the vagina to the lower part of the uterus. It's very simple because you cannot need to identify this vessel. You compress the anterior wall and then to move and compress the posterior wall. It's very effective, especially in case of placenta previa. But for this reason, it's very important that you move the bladder down in these cases before you deliver the baby. Why? Because you need additional time to dissect the bladder. And you know that if you have a continuous bleeding, you have a problem of coagulopathy after that. This is another view of the procedure. It's very simple to use and it's very practical. In summary, you need to know that the optimal dose of oxytocin drug need to be determined because there is a lot of alternative. The lack of uterine compression is the first cause of persistent uterine bleeding. And when you have persistent uterine bleeding, you need to use immediately some kind of vascular control in the uterus. More simple to use the clamps or uses, for example, the bandage. And you know that all continuous bleeding produce coagulopathy. Thank you very much for your attention.